Support for this podcast is brought to you by Genentech, the maker of Vabysmo, faricimab SVOA. Do you follow us on LinkedIn? You should. Stay current with our latest updates and hear from leading experts as they share their real-world experiences. Search Vabysmo, that's VABYSMO, on LinkedIn to find out more and give us a follow.
Welcome to the new Retina Radio Journal Club with VBS. My name is Barton Blackorby from the Retina Institute in St. Louis. I'm joined today by Katherine Talcott from the Cleveland Clinic.
Thanks so much for having me.
And Hong-Uyen Hua from the University of Miami.
Hi there, thanks for having me.
And today we're going to be discussing a paper titled Retinal Sensitivity and Retinal Perfusion in Diabetic Retinopathy. Is authored by Jennifer Hamilton, Perez, and colleagues, and is published online in the JAMA Ophthalmology Journal in October 2025. So, Dr. Hua, do you want to give us a quick summary of this paper?
Absolutely. So this was an interesting paper, which was a prospective longitudinal cohort study looking at association between retinal sensitivity of about 110 degrees and projection perimetry and retinal perfusion with ultra wide field angiography at baseline and changes at 1 and 2 years in the study eye. A little bit about the background and rationale of the study. So the functional relationship between non-perfusion and retinal sensitivity across the retina and how it evolves over time remains poorly understood. So these researchers sought to further characterize the association between retinal capillary non-perfusion and retinal sensitivity in eyes with moderate to severe diabetic retinopathy over up to 2 years of follow-up. To do so, they designed a prospective longitudinal cohort study at a single center in the United Kingdom, and these participants were followed up to 2 years with amassed outcome assessors. The participants in this study included adults with moderate non-proliferative diabetic retinopathy, severe NPDR, very severe NPDR, and proliferative diabetic retinopathy with less than high risk characteristics. And at least one eye had to be naive to treatment, and they had to also have no other retinal issues. The primary outcomes in this study included an association between retinal sensitivity, measured by 110 degrees projection perimetry, and retinal perfusion status, assessed with ultra-wide field angiography at baseline and changes over 1 and 2 years. Secondary outcomes included rates of change and sensitivity deficits over time in perfused versus non-perfused retinal areas, and also looked at demographic and clinical correlates. The findings in the study with 44 patients with at least one parametric exam included the mean age of 52.1 years. 29% of these patients were female, and the median hemoglobin A1C was about 9.1%. The mean best corrected visual acuity in the study was 20/20. At baseline, sensitivity deficits were larger in non-perfused areas, about 11.8 decibels, versus perfused areas, 6.6 decibels. The age was the only factor positively correlated with greater sensitivity deficit in the study, interestingly. So A1C trended, but was not significant. Diabetic retinopathy duration and diabetic retinopathy severity were not positively correlated. A significant portion of perfused areas showed greater than 5 decibel deficit, and a notable fraction of non-perfused areas had normal sensitivity, which indicated imperfect structure-function correspondence. Over 1 year, sensitivity deficits decreased at similar rates in perfused and non-perfused regions. Over 2 years, sensitivity deficits were more pronounced in non-perfused areas compared with perfused areas. So, in conclusion, retinal capillary non-perfusion is associated with larger baseline retinal sensitivity deficits, but functional loss may be present in perfused regions and preserved in some non-perfused areas. Sensitivity deficits tended to improve over time despite poor glycemic control and advanced diabetic retinopathy. These dynamics should inform clinical management in the design of interventions targeting capillary non-perfusion in diabetic retinopathy. Retina ischemia and retinal function within areas of perfusion and ischemia in diabetic retinopathy is multifactorial and complex. The impact of retinal ischemia on function isn't uniform.
Thank you so much, Dr. Hua. That was a great summary of the paper. I'm going to pass it over to Dr. Talcott here for a quick reaction. How do these findings align with how you currently think about non-perfusion as a driver for maybe functional vision loss in diabetic retinopathy?
Yeah, I think this is a really interesting paper, and Dr. Hu, I think, did a great job summarizing it. I applaud the authors for doing such a great job organizing the study and testing sensitivity of the retina, because I don't think that's something we can sort of test normally in our clinic. And to be honest, I don't really think about it every day in clinic as much, because when I think about my diabetic patients and them sort of losing vision, I think about it due to sort of complications like diabetic macular edema or like bleeding or detachment. But to be honest, I don't think about sort of functional peripheral vision loss as much as sort of I maybe should. And I think reading this paper and discussing this paper makes me think that maybe we should spend more time thinking about it. Like I think about sort of central non-perfusion impacting visual acuity, but for me, thinking about peripheral, functional vision loss is not something that I always think necessarily drives my treatment or management of these patients. But I'm really curious to hear what you guys think about this paper.
Right. I'm kind of in your camp. The only time that I've typically thought about the peripheral functional field is after I did a PRP and my patient came back and said, "Hey, I got a little bit of a tunnel vision here," but it is important to them. And I do think it's an argument that is played out now within, retina conversations where people saying, "Well, we've got these great anti-VEGF drugs with PDR. Maybe I don't need to do PRP with good follow-up," versus the camp that says, "No, we need to do PRP." So I think we're going to look at that peripheral perfusion and that function level a lot more to help drive the right treatments for these patients. What do you think, Dr. Hua?
Yeah, I definitely agree both of you with regards to, I guess, the clinical application of this study. I think more of, okay, how much of non-perfusion is present and how at risk are these patients of advancing to proliferative diabetic retinopathy more. That's typically how I think of the periphery as compared to the functional sensitivity of these areas.
And when we get back from the break, we're going to talk about some of these changes we saw in perfused areas and how they may or may not correlate with the function that Dr. Hua summarized with this paper. So stay tuned. In a few minutes, we'll be diving deep into these details.
Support for this podcast is brought to you by Genentech, the maker of Vabysmo, faricimab SVOA. Do you follow us on LinkedIn? You should. Stay current with our latest updates and hear from leading experts as they share their real-world experiences. Search Vabysmo, that's VABYSMO, on LinkedIn to find out more and give us a follow.
Welcome back to the new Retina Radio Journal Club with VBS. Let's get into a longer discussion about the paper Dr. Hua summarized in the first part of this episode. Talcott, I'll start with you first. What factors might explain why some non-perfused retinal areas retain a normal sensitivity while some perfused areas show a marked functional loss?
Yeah, I think that's a really good question and something that I sort of found curious as I was reading the paper. And I think the authors did a nice job sort of thinking about that in their discussion. Even if there's technically blood flow sort of in the retina, it doesn't necessarily mean that it's functioning well. We know that there can be inflammation going on. There's a lot of interest in that as it applies to diabetic retinopathy and diabetic macular edema, especially with a lot of discussion with new agents and sort of IL-6, other mediators. There's also oxidative stress that's present as well. And so all those things can impact the way a retina is functioning, even if the perfusion doesn't look good. And so I think that might help to explain a little bit why we didn't see in this paper that there was perfect structure function correspondence.
And Dr. Hu, you mentioned earlier about the role of OCTA and how that can play into the looking at the ischemic nature of the peripheral retina as well as the macula. It's actually one of the modalities they'll look for to see that fine detail for macular ischemia. What limitations do you see that potentially fluorescein angiography has on the assessment of perfusion that OCTA, wide field OCTA, might give us?
Yeah, I would say that ultra wide field fluorescein is only able to give us more of a two-dimensional picture of perfusion, whereas OCT angiography, we're able to look at, different slabs and different layers of perfusion within the retina. So it would be interesting to see a parallel study of the effects of retinal perimetry using ultra wide field OCT angiography that's available in research studies as well.
Let's talk about some of those modalities we have available. Not all of us have ultra wide field OCTA. A lot of us have fluorescein angiography, and some of us have the ability to test peripheral visual field and perimetry. But Dr. Hua, what challenges do you think clinics might face in integrating this wide field perimetry or a similar function testing into just a regular diabetic retinopathy exam?
Yeah, I think real world applications of retinal perimetry could certainly be challenging. If you think of busy retina clinics, certainly the last thing I'm thinking about is using even a Humphrey visual field to look at how my patients are able to see in the periphery with diabetic retinopathy, and how their non-perfusion is affecting, or their, even if patients have panretinal photocoagulation. I have never ever used a visual field to assess their function there. So I think it might be a challenge for retina specialists to apply retinal perimetry in the clinical setting.
How about you, Dr. Talcott in Cleveland? I think this is something that might be a challenge or usually integrated into your clinic.
I think it'd be really interesting to figure out how long it took to do all these tests on these patients.
Hmm.
Because I can only imagine sort of correlations from things like the Maya or like microperimetry that are currently, often used in trials for our AMD patients. I know those can be really cumbersome and really depend on a patient's fixation. So I can imagine that there's a lot of challenges here. I know I was personally really excited to hear that visual fields are kind of going away from the screening recommendations for Plaquenil for us. So to sort of add back in sort of visual field component is just, it's challenging in like a busy clinic. You have to feel like that test is giving you something that will allow you to sort of change your management of these patients. And so I think that that piece is still sort of out there, needs to be sort of flushed out if this is going to be integrated into sort of busy clinical practices.
Right. And if I look back to my residency days, I think a visual field was like 15 or 20 minutes. And it's definitely an exam burden and a patient burden. They're already going through a lot in terms of their testing. As we look at as we kind of see more of an interest in this peripheral visual field and function, it reminds me of a few years ago when I was at AO, I tried out a device called a Retinal, and you use it in the clinic at the chair side, and it gives you just a full field ERG of your retina. It was very easy to do, and they did provide kind of a diabetic retinopathy score to look for intervention. Certainly something that I would need to look into more, as well as this peripheral perimetry. But I think as we get more tools available to look at the peripheral retina of diabetics, it's going to be kind of the next frontier. I think we have macular disease under well control. Now it's seen that peripheral retina that may need the help a little bit more. So we learned about the functional and perfusion of the peripheral retina in diabetics in this paper. Now let's see how that applies to our clinical judgment. Dr. Talcott, did this influence you in terms of applying PRP or anti-VEGF for patients with non-perfusion and potentially good function?
Yeah, I think that's a really good question. I used to really worry about adding PRP in for some of my PDR patients, that it can certainly limit their peripheral vision. But I feel like the Protocol S study actually taught us a lot in looking at those 5-year outcomes, because in those studies, there was no difference in the visual fields between patients who got PRP versus patients who were continued on anti-VEGF injections for 5 years. So, although that's something that I used to worry about a lot, now I don't, because I think in a lot of ways, I mean, I think peripheral non-perfusion probably does impact patients, peripheral, vision. And so, even if we treat it with laser versus not, the underlying disease still impacts things.
What about you, Dr. Hua?
Yeah, for me, it's more important to prevent progression of disease. And so that's what I tell patients. It's more important for us to preserve your long term central vision. And hardly any patients, it's a rare patient that really complains of their functional peripheral vision loss. So it hasn't really changed my clinical management.
Yeah, I'm a bit of a mix. I will give some patients the options of anti-VEGF versus PRP, but I tell them if you miss one appointment or you're late, there is no option. You just get laser after that.
Mhm.
Well, I do appreciate you guys discussing this paper with me. I think it was a great paper to dive into. It'll open up even more in the future. For everyone listening at home, in your car, or wherever you are. Thank you for listening to the new Retina Radio Journal Club with VBS. Stay tuned for future episodes.